Hello, hello, hello. Hello, happy Thursday, everybody. Welcome to a virtual morning report. Thank you all for joining us today and for being here despite the tweaks time. It's special for many, many reasons today. The first is that it's been a long awaited time for me personally to co-discuss with my dear friend, Kirtan. We always hang out a little bit before we do this for a few minutes before. And as soon as he turned his video on, I saw his amazing pink shirt, which I think he only wears for special occasions. So I'm touched that today is a pink shirt day for you, Kirtan.
Yes, thank you so much for the kind introduction. And it's a special day for two reasons. First is that I am discussing with Dr. Rabi after a long time. And secondly, our dear team member, Deborah, is bringing her dad to present the case. So welcome, Dr. Michael. So kind of him to take the time to present the case to us. And maybe I would ask Deborah and Dr. Michael to introduce themselves before we can move ahead.
Hi, my name is Deborah. I'm part of the CPS Solvers team. I think everyone already saw me. And today I bring my dad that will present the case.
Okay, let's go. My name is Marcos. I've been a doctor for 30 years, ear, nose and throat, and emergency all the time. And we learn a little bit about everything. The medicine is a very wide area to learn, and you can study all the time, forever and never learn everything.
Dr. Marcus, thank you so much for joining us. We're honored to have your experience brought here to the platform. Is heartwarming and to say the least. I'm curious, how did you do both ear, nose, throat, and emergency? In the United States, that is an uncommon overlap, but I'm curious if it's different where you are or what that story behind that is.
It was a coincidence. First of all, I worked with emergency, and then I decided to make ear, nose, and throat, but didn't leave emergency.
Wow.
Because emergency makes us to learn more, to understand more. And there is always something new to learn. Even in the same case, we have always something new to learn. I like it. I like it.
Well, thank you for teaching us all today. We're ready whenever you are with your case. Thank you.
Okay, thank you.
Can we start?
Yes.
Wait for colocar.
It's okay.
Wait. Tem que compartilhar a tela.
Sorry about that, Robbie. Both of you should be co-hosts now.
Okay, so
we have a patient, 28 years old, male, with abdominal pain over the past 10 days. Okay.
Do you want more information?
I think we can start with this much information and then we can get the HPI. So talking very superficially about the abdominal pain. So what I have learned from our dear team member Jack, that how we can categorize abdominal pain. So first we have to ask ourselves that whether the abdominal pain is originating from the abdomen itself or is it originating from extra-abdominal system? Like, is the pain coming from thorax? Is the pain coming from the back, that is the spine part, or is the pain coming from the pelvic region? So that is the first part. And then, we can look at all the organs and having knowledge of which quadrants are involved prominently can guide us differentials. So like, is the gallbladder involved? Is the colon involved? Is the pancreas involved? So all that sort of information can guide us that where the abdominal pain is coming from. And then the severity of the abdominal pain, that whether it is 10 out of 10, whether it is 5 out of 10, and even the acuity of the abdominal pain. So like what are some of the must not miss conditions? Like could this be some sort of obstruction? Could this be a vascular event? Could this be a perforation? So must not miss events are high on our differentials. And then once we have ruled out those differentials, we can move to less benign causes or less malignant causes, so as to say, and then we can shape our differentials in that way. So as of now, I think that having the time course and the location of abdominal pain is going to be very important once we get the HPI. And before we move ahead, I would like to ask Dr. Rabi if he has to share some thoughts before we can move ahead.
I think that approach is superb. And it's, it's curious, the 10-day mark. The 10-day mark is kind of in the middle. What does it mean that somebody has waited 10 whole days for evaluation of abdominal pain? 10 days. Can you imagine that? 10 days. What does that mean? And I think it either tells you a lot about the person, the human being, or it tells you a lot about the disease process. But track that. Most people presenting to the emergency room with abdominal pain will only tolerate the abdominal pain for a few days, not 10. So that is an interesting thing to study, and either it's a clue to the underlying disease process or it's interesting clarifying information about the person carrying the disease. But make note of that. That'll definitely be something we'll have to explain. All right, Dr. Marcus, back to you.
Okay.
Okay, so
He presents abdominal pain for 10 days, and in the umbilical region, intermittent irradiated for the back. Associated with icteric, started 90 days ago, and some episodes of vomiting. He presented asthenia, anorexia, and adenophagia. Okay. I remember that his icteric stage started 90 days ago, and the pain 10 days. He denied fever, acolia, coluria, hematemesis, and the blood escape. His past medical history, daily alcohol abuse that started with 15 years old. He started 15 years old and he's 28 years old. He stopped 4 days before getting in ER. Then 4 days he stopped. Schizophrenia, and he took 2 doses for COVID vaccine. Okay, medications. Irregular use of risperidone, naltrexone, and escitalopram oxalate. Irregular. His behaviors, he don't smoke, don't use drugs, and allergies, he denied allergies, and family story, mother had eclampsia. Okay.
do you want more information?
I think we can stop here. Already we have got lots of data to digest. And it already seems like a very fascinating case. So maybe I will talk a little bit about the HPI, and then I will ask Rabi to tackle the past medical history part, that how we can integrate it with the HPI. So in the first helicopter, we discussed about the anatomical approach. So now we can apply it since we have the HPI. So now we know that the pain started in the umbilical region and it related to the back. So what are the common conditions in which pain can relate to the back part? So all the retroperitoneal organs, if they are involved, then pain can relate to the back part. So things like pancreatitis or retroperitoneal lymphadenopathy or retroperitoneal inflammation in any way can result in pain in the back part. And another way to link is maybe the intercostal nerves are involved. So remember in first helicopter, we discussed that how the pain can be originating from the spine part, and then we are feeling it around our abdomen. So involvement of spine is something that we can consider when the pain is relating to the back part. And now how we can link the anorexia, odynophagia, and all other things. So numerous infections, whether it be viral or bacterial, then in the prodromal phase, you can get these non-specific symptoms. But odynophagia, that is very specific, because odynophagia points us towards esophagitis or something wrong with the retropharyngeal structures. So, kind of like retropharyngeal abscess, maybe pharyngitis is there, laryngitis is there, maybe thyroid is involved, maybe thymus is involved. And if it is indeed odynophagia, then what are the risk factors for some of the infections which can lead to odynophagia? or are there some other conditions which are at play? So at this point in time, we can of course say that maybe it is infection, but there may be inflammation as well, and malignancy seems unlikely because of the time course, but still we can't rule it out as such. So now we will learn from Dr. Rabi's wisdom that how we can narrow down these possibilities based on the past medical history. So Rabi, please take us away.
Kirtan, that was absolutely superb. And I love the parts that you focused on with the radiating to the back and the odynophagia. Those are very, very powerful clues, as is the icterus. And I think that a key question to ask yourself is, when is the use of medical history to guide the analysis of the case helpful? Because some people will tell you, don't over prioritize the medical history because it leads to anchoring, right? But sometimes if somebody has, for example, a history of HIV, you know, it radically changes the differential diagnosis. And in some ways, when you have a certain medical history, it actually broadens the differential diagnosis, as is the case with patients with HIV, rather than narrows it. So what does the relationship of alcohol use have to do with icteric abdominal pain? And it really, really adds things to the differential diagnosis that you might not initially consider. The best example is alcoholic steatohepatitis, which is a condition that you probably wouldn't entertain absent the alcohol use. So it's an interesting reflection to ask yourself, when is it wise to use background data upfront, or when is it leading to bias? And here, alcohol is such a prominent player in patients with abdominal pain that it's hard not to ignore its value. The most common categories are actually lab positive diseases. So alcoholic steatohepatitis, alcoholic pancreatitis, and alcohol-related ketoacidosis are the three diseases you can definitively suspect based on initial laboratory elevation with liver enzymes, lipase, and a beta-hydroxybutyrate. There are also a lot of diseases that are negative on initial labs related to alcohol, including alcoholic-related gastritis, Mallory-Weiss tear, and a rare but important condition called GI beriberi, or GI thiamine deficiency. But more importantly, what happens in real life for this patient is, you know, you need to get your blood evaluation, and you will do that, but you have to be aware of two things. One, what is the actual diagnosis? And two, what is going to happen to the patient now that he doesn't have access to alcohol? So not only are you powering through towards an answer, you're making sure that you don't let him suffer the consequences of alcohol withdrawal. And now I think the initial question has been answered. Why did it take 10 days to present to care? And you have that background data. You have alcohol use disorder and schizophrenia, both conditions associated with deviation from the expected presentation styles. So that piece of information will be very, very important for you to be cautious about not making assumptions about how long this has been going on for, how severe it is, because these background information taint and adjust the story. So exam and labs will be crucial. And if it's exam lab negative, we'll have to entertain esophageal causes and gastric causes, as Kirtan mentioned. All righty, back to you guys.
Okay.
Okay, so for the physical exam,
So on physical exam, temperature 37.1 degrees Celsius, blood pressure 116 per 6.7, and
heart rate
91, and aspiration as 18 a minute, and saturation 97%. He's fine. General, awake, lucid, oriented, jaundice, yellowing of the skin and the whites of the eyes, dehydrated, and heart, okay, normal, lungs, okay, normal, abdomen distended, pain and palpation in the umbilical area. I repeat, his abdomen was distended, and had pain and palpation in the umbilical area. Neuro, normal, no flapping tremor, no edema. Hematology,
White blood cells.
white blood cells, 11,020. Hemoglobin, 11.9. MCV, 101. And platelets, 1,700. Chemistry, the sodium, 135, potassium, 3.5.
Urea, boom. Esse é ureia, boom.
Urea, 25. And creatinine 0.7, glucose 103, and the calcium 8.5. AST 216, ALT 58, and total bilirubin 45.1, so high, 45.1, direct 31.52, indirect 12.89. Albumin 2.5, gamma GT 315, alpha alkaline phosphatase 184, LDH 444, amylases 254, and lipase no, he didn't make lipase.
Do you want more information?
So I think we have got so much data. Oh my God. And Deborah, I just wanted to clarify one thing, that the platelet count was like 170K or like 1770. Like just wanted to make sure.
Wait,
Yeah.
I think he's wrong. The platelet was 170,000. No, it was okay. Wait, sorry.
Yeah, no worries. And regarding the bilirubin, the total bilirubin is 45.1, right? Because it's just one of those labs that shocks you. So high bilirubin. All right. Yeah.
And may I ask one question too, just for our lab? Do you have INR, PT, PTT, or?
I don't think so. I will check.
No problem.
Sure. So we have a lot to discuss, Rabi. So maybe I can tackle a little bit of past medical history, which I wanted to allude to in the previous discussion, and then the physical examination, and then you can help us with the labs parts. So in the past medical history, there is one thing which is important, that the patient is on 3 medications. So now, can those medications lead to our presentation? So as it turns out, it may be, because naltrexone is one of those drugs which can cause hepatitis. And I have learned from Reza only that whenever you are suspecting any drug to be a cause of some sort of injury or complication, then you can always check the online resources. So like there is a website known as livertalks.com, in which you can see if some medications are known or more likely to cause hepatitis than others. So naltrexone is one of those drugs which can cause hepatitis and all the symptoms. So maybe that is something we can keep at back of our mind. Now talking about the vitals part, the patient is relatively stable. So the dangerous part, like if there is some sort of perforation, if there is obstruction or vascular infarction, so that is less likely. And the abdomen was distended. So what to make of it? So we have a beautiful schema on our CP Solvers website as well. So many people can check it out as well, that what can lead to abdominal distension. So maybe it can be due to a fluid filling inside the abdomen. So what kind of fluid? Is it the blood, as in hemoperitoneum, or is it the ascites? And if it is indeed ascites, then we can go down that path, that whether it is transudative or exudative. And apart from that, is it related to organomegaly? Like whether we are dealing with hepatosplenomegaly, which is leading to abdominal distension. On examination, there was no evidence of hepatosplenomegaly, so that is less likely. And why the flapping tremor is important? Because since if we don't have flapping tremor, then it means that liver synthetic function is still preserved and we are not going into the fulminant liver phase. So that is important. And sometimes to rule out the Wilson's disease in young patient like ours, it is necessary to see if the patient has evidence of hepatic NCAF. So that's why no flapping tremor is also important. So positive findings are important, but even negative findings are important. So that was my take home point from this physical examination. And now Ravi, can you tell us that how we can interpret very high bilirubin levels, like so high?
Of course. Yeah, I think that the lab actually tells you an answer, believe it or not. And I think that recognizing that pattern is very, very important. But let's be systematic to layer onto the analysis that Kirtan gave us, which is that this patient, the abdominal distension is certainly very, very important. And focuses on abdominal causes, but the liver pushes us into, the labs push us into the liver. So how do we begin this analysis? First, that you have to make sure that when you're analyzing anyone with direct hyperbilirubinemia, that you ask yourself, is it in the liver or is it the drainage system of the liver? So is it intra or post-hepatic? And whenever you have concomitant AST, ALT elevation, that is a powerful clue that the disease is in the liver itself, but not as powerful as the presence of portal hypertension. So portal hypertension tells you that you're dealing with an intrahepatic disease unless the patient has risk factors for primary sclerosing cholangitis, which is basically the only real extrahepatic disease that can cause a portal hypertension from the extrahepatic space. So here you say, you know what, as Kirtan said, the distended belly, concerning for ascites in the presence of liver injury, the case for intrahepatic disease is high because there's AST, ALT elevation, and there is portal hypertension. But it's not high enough to prevent you from getting imaging to make sure that the extrahepatic bile ducts are okay, but you can predict that they probably will be. So the question is, what kind of intrahepatic disease process is this? And it's not just any intrahepatic disease process. It's an intrahepatic disease process associated with portal hypertension. So therefore, it must be a disease between the liver cells and the bile ducts. Let me explain. If you just have liver injury, AST, ALT rise over 1,000 without portal hypertension, it's a disease of the hepatocytes, like hepatitis A, hepatitis B. If you have a disease of just the bile duct cells, like primary biliary cholangitis, you just have a high alk phos, high bilirubin, but you shouldn't have portal hypertension. Portal hypertension means those small veins in the liver are squeezed. So what is squeezing them? That analysis is answered by saying, is it just a liver disease or is it a systemic disease with liver involvement? And here there's no other system involved. It's really just the liver. So the causes of isolated hepatic portal hypertension are either cirrhosis or infiltration by fat. And here, the patient might have both. He has alcohol use, significant over a long period of time, and is at risk of cirrhosis, and that is a possibility. But what he certainly has is alcoholic steatohepatitis. Now, how do we know that? We know that because it is one of very few diseases that causes a devastatingly high bilirubin. There are others. Acute fatty liver pregnancy is an example, which this is not the case. Leptospirosis, and a few others. But in a patient with this liver panel with such high bilirubin, out of proportion to any other marker of synthetic function, in conjunction with a leukocytosis, probably will end up getting treatment for alcoholic steatohepatitis, but you have to make sure he doesn't have spontaneous bacterial peritonitis or SBP. So Kirtan, I think the labs here are very telling. The height of the bilirubin in a patient with alcohol use is a very strong predictor of alcoholic steatohepatitis. So I'd be worried most about that. I'm curious, since there's so much information in the labs, what else struck your fancy and what other thoughts you might have had?
Sure. So as you are thinking about the alcoholism, I was also looking at the AST-ALT ratio. So if you see that AST-ALT ratio is more than 2, now we know that it is not very specific for alcoholism, but it definitely raises the suspicion that maybe alcoholism is the cause of liver injury in our patient. But there is another thing which struck my mind when you mentioned that why bilirubin is out of proportion. So in Wilson's disease, when we have the fulminant liver failure, there are two left findings that we have to focus on. First is AST-ALT ratio, which is more than 2.2, and another is alkaline phosphatase by bilirubin ratio. So usually alkaline phosphatase upon bilirubin ratio is less than 4 in patients with Wilson's disease. And you can imagine that bilirubin is in the denominator part. So if bilirubin is out of proportion to the alkaline phosphatase level, then the ratio will be less than 4. And since this is a young patient, I would also like to ensure that we are not missing the diagnosis of Wilson's disease. And I would also like to focus on the LDH part. So what are we thinking when we see the elevated LDH? We know that LDH is present in the cells. So it is present in RBCs. So maybe the patient has hemolysis. And you know the MCV is elevated. So maybe reticulocytosis can push the MCV just on the 100 and 105 border. Where else is LDH? LDH is present in the hepatocytes. So as Rabi mentioned that we are dealing with hepatocellular injury. So maybe the LDH is elevated because of the liver injury itself. So those are the two primary things, that whether RBC breakdown is leading to elevated LDH or whether the hepatocellular injury is leading to elevated LDH. So keeping those possibilities in mind, we can move ahead that whether we will get the USG Doppler of the liver to make sure that patency of vasculature is there. Maybe we can get CT scan to make sure that we are not missing the extra hepatic biliary obstruction, as Rabi mentioned. So I guess imaging studies will really shape our path forward. So looking forward to hear the next aliquot from you, Dr. Marcus.
Okay, so
Chemistry.
and here, serology.
So now serology, two different exams, quick test and ELISA of HIV negative, hepatitis A, B, and C negative, or syphilis negative, BAAL negative, ultrasound of the abdomen. He did 4 days before getting in the ER, liver normal, echogenicity, moderate high of parenchymal, steatosis of the liver, grade 2, moderate, pancreas with no cystic and solid lesions, OCT abdominal pain with contrast, liver normal size and diffuse steatosis, small points of calcification on the pancreas.
Pronto, that's it.
That's it.
And that's it. And we have one more diagnosis.
Wow. Ravi, why don't you go ahead this time? I want to learn from your wisdom this time.
Of course, my friend. I think that, you know, the main value here is the stuff that doesn't show up in the glitter. You know, there is no extrahepatic disease process, and the calcifications in the pancreas are telling of his chronic exposure. And it's surprising that he has no
I think we lost the Rabi. No worries, I can discuss few things. Meanwhile, Rabi can jump back. So yeah, Rabi was telling us that there are a few pertinent negatives. So we have to be careful about the pertinent positives as well as pertinent negatives. And I just wanted to clarify one thing from Deborah, that in the USG, we had the evidence of steatosis based on the parenchymal echogenicity, right?
Yes.
Yes, sure. So Rabi, sorry, we lost you for a second. So please continue.
No, I think I heard you summarizing. I think it's all about the pertinent negatives here. And the one thing just to practice our differential diagnosis is, what does it mean to have steatosis in a 28-year-old? So I think there is an answer in this case that is obvious, is alcohol use, but we always want to make sure that there's nothing else hidden. But yeah, that's my take. What's yours?
Yeah, sure. So I was also thinking along the same line that the most common cause of hepatic steatosis is alcoholism. And after that, the most common cause is non-alcoholic steatohepatitis. And usually it is seen in patients who are obese. So in our case, we don't have that information as of now to make that decision. So alcoholism is really the priority now. And as you were mentioning, that alcoholic steatohepatitis is one of those causes which can cause very high bilirubin levels. So it is certainly high on our suspicion. But I would love to learn more about how to evaluate the steatosis in a young person from Dr. Marcus, and what are other possibilities that we can keep in mind apart from alcoholism?
So the last thing, the last found was
Endoscopy, esophageal candidiasis, KODSI2. And the patient had chronic pancreatitis, alcoholic hepatitis, jaundice, and esophageal candidiasis. Was associated with heavy abuse of alcohol. Esophageal candidiasis, esophageal candidiasis is one of the major, let me see, one of the major opportunistic fungal infections that occur in the patients. Over 90% of the HIV infected, but he's not. During the course of their illness, majority of HIV negative patients with EC were using alcohol 70%. Okay. And
so yeah, this case, we saw that the patient had the chronic pancreatitis, the alcohol, hepatitis, the jaundice, and then the last find was the esophageal candidiasis that we felt that was really interesting because the patient didn't have HIV. So I have looking for in patients with HIV negative, alcohol abuse is a common disease that is associated with esophageal candidiasis. I always thought with HIV, so I think that was the interesting part of the case, and that's it.
Thank you so much, Deborah and Dr. Marcus, for enlightening us. And before I pass the mic to Rabi to summarize the case, I just wanted to highlight one point that in the first aliquot, we're thinking about the esophagitis with odynophagia part, but then we're thinking about maybe the patient has HIV, and that's why, CMV and EBV can cause esophagitis. But one interesting thing that I can point is that in immunocompromising conditions, HIV is the first thing that comes to mind. But often in textbooks and journals, we read that things like CKD, alcoholism, diabetes, malignancies are also immunocompromising, right? In our case, I know that alcohol has multifactorial effect. I mean, it has direct erosive effect on esophagus, and there are so many other factors as well. But keeping at back of our mind that what can be the immunocompromising conditions apart from HIV. So like alcoholism is right there. You always see it in journals and books. So I guess if we had focused on that part, then maybe we can reach to this diagnosis earlier and make sure that confounding part of esophageal candidiasis is not hindering to reach the main diagnosis of alcoholic steatohepatitis. So Rabi, can you enlighten us that what we can learn from this case?
Oh, I think you should learn from listening to Kirtan over and over again. And I think the one thing specific to emphasize is the issue of proportionality. It's not so much that the bilirubin is high. It's that the bilirubin is in ridiculously high proportion compared to everything else. And I would guess that this patient's INR is no higher than 1.5, 1.6. I don't know, we don't have that data. But the story of alcoholic hepatitis is a disproportionate hyperbilirubinemia with relative sparing of the AST, ALT, ALK-Phos, and INR. And whenever you see a patient like that, you're dealing with diffuse fatty infiltration of the liver, which is often from alcohol, but can be acute fatty liver of pregnancy and other rare associations. So I think this case is a great reminder of not just tracking what is elevated, but tracking the ratio of things that are elevated. AST, ALT greater than 2:1, bilirubin much, much higher than INR. That is a very compelling case for the diagnosis. And I would just emphasize, this is a highly morbid condition. It is taking a 28-year-old man and giving him a prognosis that is very poor based on a rough estimation of how bad his alcoholic hepatitis is. So I'm curious to pass the mic to our family duet here so they can teach us what they learned.
Yeah, like that. When I saw the case, I said for my dad that the patient had the esophageal candidiasis, and then he said, okay, the patient is HIV positive. I said, no, he's not. So that's what we learned, that we cannot just think about the HIV, and we have studying that to have alcohol consumption is like increase the oropharyngeal colonization by the candida, and then the patient can develop candida esophageus. So that's it. Thank you.
This is a young boy, 28 years old, started drinking on 15, and he was so fast. His disease was so fast. This is a common case in the hospital. And an example, we can drink, but not so much. Okay, I'm not against drinking, but less.
I think that one, we're so grateful that you came and shared this case with us, and we learned so much. I think you saw a masterful case presentation, and I know that English is not the language that you use most frequently, and to be able to do that is just amazing. So thank you so much, and thank you, Kirtan, for your outstanding facilitation. The sky is the limit for you, and it's an honor to discuss with you. Madalena, take us home, please.
Okay, amazing. Marcos and Deborah, I can't thank you both enough for presenting this wonderful case. It was amazing to have another family member. And Ravi, Kirtan, as always, so many incredible teaching points. I was just had so many to write down. So to kind of summarize where the journey that we went through. So we started with this chief concern of abdominal pain, and Kirtan described a really helpful approach to consider first the intra-abdominal organs and then extra-abdominal organs like the thoracic and pelvic organs. And then beyond that, you can use an anatomical approach to drive your differential. And we talked about the example of if there's radiation of pain to the back, you want to consider retroperitoneal organs in addition to kind of radiation from intra-abdominal organs. When we got the additional detail of odynophagia, we wanted to be sure to consider esophageal and retroperitoneal structures. And then with abdominal pain, making sure you layer on the time course and the severity into your differential, being sure to not miss highly morbid diagnoses, including obstruction, perforation, ischemia. And then Ravi shared with us this really interesting question about, when is using the medical history to guide the diagnostic approach useful? And the risk of relying too heavily on the medical history is that it can lead to anchoring and to bias. But there are many cases when it's useful. So for example, in a patient with HIV, we know that that generally expands the differential of infectious causes they could likely have. And another example we talked about is alcohol and abdominal pain. So there are lab positive diagnoses for alcohol and abdominal pain, like alcoholic steatohepatitis, pancreatitis, ketoacidosis. There are lab negative diagnoses, including alcoholic gastritis, Mallory-Weiss tear, GI beriberi. And then moving on to the physical exam, which showed an abdominal distension. Kirtan walked us through the phases of matter approach. So is it liquid, meaning could it be blood like a hemoperitoneum or ascites? Could it be solid like hepatosplenomegaly, or could it be gas? And then for labs, we got a lot of rich data here, and we focused initially on the direct hyperbilirubinemia. And the initial branch point you can use is this an intra or a post-hepatic cause? And when you see a concomitant AST and ALT elevations, that generally suggest pathology within the liver. And when you have signs of portal hypertension plus intrahepatic disease, the two causes you want to think of are cirrhosis and then infiltration by fat. And when you have a significantly high bilirubin, generally that only leads you to a few differentials, including steatohepatitis, acute fatty liver disease of pregnancy, and leptospirosis. And then a new piece of data for me that Kirtan shared was this lab details that have a high specificity for Wilson's disease. So that's the ratio of ALK phos to T-bili less than 4, and then an AST to ALT ratio greater than 2.2. And then we ended with, when you have steatosis in a 28-year-old beyond alcohol-induced beyond alcohol use, you also want to consider non-alcoholic steatohepatitis. So amazing case, you guys, and thank you so much for all the learning points.
Absolutely awesome recap. Thank you so much. All right, see you all next time. Bye.